faculties, and member delegates. We are all set to start our much-awaited annual conference, FPACON 26. Our two differences are there in this conference from the previous ones. One is that we have moved out from a star hotel to a star auditorium. And the second is that we are giving CME points allotted by West Bengal Medical Council for the first time. The scientific sessions have been divided into two parts, pre-lunch and post-lunch. We have 10 sessions in the pre-lunch session and 8 in the post-lunch session. I'm looking forward to an eventful day today, and now I would like to hand over to the Master of Ceremony, Dr. Amitava Datta, for the day, who will conduct the program.
Thank you, Chairman, sir, for the privilege offered to me. First of all, ladies and gentlemen, good morning. Wishing you a very happy new year 2026. May this year 2026 be filled with success, prosperity, good health, and positive achievements for all of you. Friends, it is that time of the year when we converge one and all to treat ourselves to a delicacy of academic fiesta and advanced knowledge in all spheres of modern medicine. The 29th edition of FPACON 2026. A strong contingent of 165 delegates are attending this year's conference, and I presume most of them are present already in this auditorium. If not inside, they may be having their breakfast outside. This presence of delegates is in spite of the recent spell of cold wave sweeping across the city of joy, but inside the auditorium we have a very pleasant weather and a very pleasant atmosphere. As Chairman Sir mentioned, this is a landmark conference in two aspects. The first one is that this conference has moved out of a star hotel for the first time in our history of 31 years. The FPA started running as a registered organization in the year 1995 with the first president, Dr. Mabud, and the first secretary, who is amongst us, Dr. Pramod Jasani. We are very lucky to have him amongst us till now. Now, this FPA has covered several glorious years, and we are now approaching the 29th edition of this FPACON. Today's program is a total of 10 pre-launch sessions, followed by a glittering inauguration ceremony, which will be illuminated by several dignitaries from the medical world, a sumptuous lunch, an 8 post-lunch session, followed by the valedictory session, delegate kit, and early bird prize distribution. Few ground rules are there for the delegates attending this conference. First, keep your mobile phones in the silent and the vibratory mode throughout the conference. Keep your mobile phone in the silent and the vibratory mode. Second request is, do not leave your seat while a particular session is going on. You can leave your seat in the small interval between two sessions. Third, no question and answers are allowed during the conference. As you know, it is the tradition with FPA, no question answer sessions during the conference, during the sessions. If you have got any queries in your mind, you can catch up with the speaker on the floor of the conference. And to drive away the cold weather from this auditorium, you will have to clap and clap loudly and keep your hands warm. With these few words, may I invite the chairpersons for the first few sessions, Dr. Chandan Pal, who is an eminent practitioner and a very senior member of the Family Physician Association, Kolkata. He will chair this session, first few sessions. Next, Dr. Rajiv Dhal will act as the co-chairperson along with him, but he is yet to arrive amongst us. As soon as he arrives, he will pick up the second chair of the chairperson. May I request Dr. Chandan Pal, if you have got the program sheet in your hand, you can call the speakers in order.
Let me have the honor to call upon the stage our first speaker, Dr. Kalyan Sarkar. Please come on the stage.
Loud round of applause, please, for the first speaker.
He will be talking on advancement of BPH. And Dr. Kalyan Sarkar, everything, introduction is everything. I think it will be available on the screen. Okay.
Sir, two rules are there for the chairpersons also. You'll have to, we are adhering strictly to time. So you have to issue 2 warning notices, one when 5 minutes are left and the other when 2 minutes are left. Okay,
thank you.
you. Over to Dr. Sarkar.
Good morning, everyone, in this very great association, and I must thank you for inviting me to speak today on the 29th Family Practice Association's meeting. I may add that I had the privilege of probably speaking in the first or second of such meetings in the beginning of my practice years in 1995 or 6. Or 7, I cannot remember, but I do remember speaking about stone disease. Now, I'm going to talk today about a subject which is of interest to all physicians, all practitioners, be they family physicians, be they specialists, be they non-urologists, and of course for urologists. Almost 30 years have elapsed since the medical therapy for benign prostatic hyperplasia was established. The question I raised before the audience, and I think you are the first people to be able to tell me, does it work? Or is it just a comfort trap? Or has convenience replaced cure? Why this topic now? The patient perspectives have changed. They want to be free of disease rather than be free of symptoms. And there are emerging data on metabolic, sexual, and cognitive dysfunctions which happen after decades of treatment with such medications. The treatment is non-invasive, easily started by anyone, as I just mentioned, and it gives rapid symptom relief, especially with alpha blockers. There is high patient acceptance and comfort, and there's a low cost and minimal monitoring. But the trap is that the medications has limitations. Medications work to only relieve some symptoms. They shrink the gland, and up to 20% progress to retention on surgery within 5 years. And there are surgical challenges in the new generation with prostate size, comorbidities, age, and the prevalent use of antiplatelets for cerebrovascular and coronary disease, and the complications of surgery in an advanced stage are really serious. And the most important thing, that there is no new drug on the horizon for the last 20 years. I will dwell on some science, but keep it as restricted. For the purpose of understanding, you need to know that the prostate sits at the base of the bladder, surrounds the urethra, and there is a peripheral zone of the prostate which produces which contains the prostatic glands. This is the site of cancer, but we are not interested in this area. We are interested in the periurethral glands. We are interested in the periurethral gland area where the disease of benign prostatic hyperplasia develops. The prostate has a central zone, a periurethral zone, and anterior fibromuscular stroma. This area develops BPH. It's called the transitional zone. You get cancer in the peripheral zone, but that is not the subject of my talk today. Now, we all know that the targets of medical therapy of the prostate are the prostate itself, the alpha adrenergic receptors in the prostate treated by the alpha blockers, the 5 alpha reductase enzymes which treat hyperplasia, and this is the finasteride, dutasteride group of drugs. And of course, recently other drugs are being used. The PDE5 inhibitors used for erectile dysfunction have some effect on the prostate, beneficial effects on patients with prostatic symptoms. And bladder overactivity is treated by muscarinic receptors and alpha adrenergic receptors. With this in mind, let us dwell a bit on the prostate anatomy. And from the zonal anatomy of the prostate, which I just mentioned, we are now concerned with the cellular anatomy of the prostate, and the root of the basic essentials of our discussion today is about the epithelial cells and the stromal cells. The epithelial cells in the prostatic ducts, which are in the peripheral zone, which I've just mentioned, and the stromal cells, which contain the androgen receptor. So what does the prostate, salient parts of prostate anatomy include regulation of the androgen receptor, and what happens? It secretes certain enzymes which have effect on semen liquefaction, sperm motility and survival, and prostate-specific antigen comes from this area. If you have cancer, then the PSA level goes up. But again, that's not the subject of my talk today. What happens in BPH? That there is an increased number of epithelial and stromal cells in the periurethral area of the prostate, and you get, this is known as hyperplasia and not hypertrophy. So there's a balance within the prostate of cell proliferation and cell death. Androgens are required for normal cellular function, but androgens do not cause BPH, but the development of BPH requires the presence of androgens. So why do we get BPH? Let us look at it in more details. I've said prostate has stromal cells and epithelial cells. Testosterone is converted to dihydrotestosterone in stromal cells. Mainly is the 5-alpha reductase type 2 enzyme, which creates dihydrotestosterone. This moves to the epithelial cells and then causes hyperplasia. So this is the sophisticated type of communication which results in BPH. So in the normal prostate, there's a balance between cell proliferation and cell death. And when you use, when BPH develops, for whatever reason, there is an interaction between growth factors and steroid hormones. So that can tilt towards more proliferation, less death, and increase in size of the prostate. So the pathophysiology of BPH is an enlargement in size of the prostate, causing a mechanical obstruction, and the activity of this the androgen drive of the alpha receptors stimulated by adrenergic neurons, which causes muscle spasm and causes the symptoms. How does the bladder respond to it? Overactivity of the bladder, detrusor instability or increased compliance, smooth muscle hypertrophy, increase in fibrous tissue within the detrusor. So the bladder is able to relax sufficiently. Prostatic symptoms are not only obstruction, it is also irritability of the bladder. And there are various changes in the bladder muscle which causes this. But what is the end result? There is progressive bladder remodeling due to bladder outlet obstruction, and this is a recent thought, and that can cause gradually to hypertrophy, leads to compensation, and then to decompensation, culminating in retention. So you treat a patient with drugs for years and decades. At the end of the year, when they reach their 80s and 90s, then the muscle fails, and then they'll end up with retention, which is very difficult to treat. In addition, apart from the alpha blockers, the prostaglandin pathway is activated in many of these patients. That is why drugs fail. So there are various drugs for BPH, as I've mentioned at the outset. And let's carry on. So alpha blockers were the first medicines, and seniors in the profession will remember that in the late 1980s and 1990s, when prazosin was used for hypertension, that had beneficial effects. They were alpha blockers. So at doxazocin, also known as Doxacard, I think. So alpha blockers, history is such, they relax the prostate muscle. Now, I will take you to a little village in the West Indies called Dominican Republic, where it was realized that there was a disease where, if you remember my talk, I said that alpha reductases convert testosterone to dihydrotestosterone. And if you have dihydrotestosterone genetic deficiency, you get female pseudohermaphrodites, where the penis enlarges and they look like males, but they are genetically females. What happens here In these patients, the prostate remains small and there is no recession of the hairlines. So this was picked up by the Merck company. You know, Merck company developed finasteride. So they realized that this drug is very good. There is no prostate development. So they used finasteride. And that was the big therapy of this combination therapy with both finasteride to shrink the prostate and alpha blockers to improve symptoms. And after 4 years follow-up, incidence of complications were reduced. So, these combination trials showed that benefited men with a large prostate or a PSA more than 1.5, and this was an effective strategy for treating BPH. However, not all patients will respond to medical therapy. They are either not adherent, or they do not respond to treatment, or disease progresses. And you have all seen these in your practices. Alpha blockers have their limitations. They are of comparable efficacy and there is no improvement in alpha blocker, there's a limit. Long-term use of these drugs can affect sexual function, metabolic function, you can have drug-related problems, quality of life is affected, and there is some recent mental health complications recognized with these medications, dementia, neurocognitive deficit, depression. And I'm not talking of drugs which have been used for a few months, I'm talking of drugs which are used for decades. And there is a difficult problem, and BPH therapy can negatively affect quality of life. And only 30 or 40% of patients, as you've all seen, persist for medical therapy with BPH. 25 to 30% of patients have no response, and 7% of patients progress despite therapy. So why do you get resistance? Because alpha blocker, alpha receptor densities vary. 30% of patients do not respond to finasteride and dutasteride because the expression of 5-alpha reductase is not there. You also get prostate inflammation. And you can identify patients who will not respond. How? Age, obesity, prostate size, higher PSA values, repeated attacks of prostatitis, large residual urines, low flow rates, higher symptom scores, large prostates with the middle lobe. They don't respond to drugs. And so all of these issues are important. So there are limitations of medical therapy. There is modest IPSS Qmax improvement. There is no true disease reversal. Prostate volume and obstruction remains. Ideally, you want a magic bullet which vaporizes the prostate. You don't have it. Delayed onset, variable response, side effects I've just mentioned. Long-term failure, and adherence is only 50% at 1 year. They may 10 to 20% will progress to retention. And there's a chronic expense which adds. If I understand that the cost of these combination tablets are 50 rupees per tablet, and if you're using it for decades, there's a huge cost. So the debate is between medical therapy versus definitive intervention. In favor of medical therapy, minimally invasive, it preserves quality of life in many. Early years, it is well tolerated and reduces the need of surgery in selected groups of patients. In favor of definitive intervention, if you do surgery or intervention early, avoids long-term adverse effects and drug dependence, offers symptom relief and more cost-effective. So, the real take-home message from my presentation up till now is that long-term medical therapy of BPH is effective, but it is not benign. If you carry on treating an obstructed bladder with variety of medications, you will develop a lot of complications. The bladder begins to fail, and there are metabolic, sexual, and psychological consequences. Patient adherence fails. And over-reliance on medicine, and this is the key fact of my presentation, may delay the necessary surgical intervention. So, Between convenience and cure, convenience has its value in early, mild BPH with regular follow-up. Cure must be pursued in progressive or complicated cases. Medical therapy offers management but not reversal of the disease, which patients want these days, and definitive treatment restores the anatomy. So medical therapy is essential but not definitive. So we have to select our patients carefully, we have to monitor outcomes and shift to intervention before the bladder decompensates. And when either the patient goes into retention and then he goes and has surgery, but the surgery does not give the desired results. So,
5 minutes more, please.
yes. So, of the common, you know all of these are doing the rounds in your in the internet, in your practice. The information when you see patients getting consultations about thermal therapy of BPH, about the prostatic urethral lift or the urolift procedure, temporary implantable nitinol devices, aquablation therapy where a jet is used to dissolve the prostate, paclitaxel, anti-chemotherapeutic drug can be instilled into the prostate fossa by balloon to shrink the prostate, and finally, the interventional radiologists are ubiquitous. They will embolize large prostates and give good results in a certain selected cases. Water vapor therapy, you inject steam into the prostate, cause a measured necrosis of the prostate, or it's a thermal ablation. And in prostatic urethral lift procedure, you can put staples in the prostate and shrink the prostate. So this has to be weighed with the standard, a century-old procedure with very good results, laser surgery, which has come up in the last 20 years and now is becoming to be very popular indeed, has some advantages, but comparable worldwide, this is still the standard procedure. Transurethral prostatectomy, which is now much safer with bipolar energy devices and normal saline procedures. The operation of simple prostatectomy is still there. A wonderful operation which our teachers used to perform 5 or 6 surgeries in a day with as good results as we provide, or better even, admitting the morbidities. And these days, this is an emerging technique of surgery called the robotic simple prostatectomy, where a very large prostate, you've all seen patients with 150, 200 gram prostates, which are very difficult to handle by these techniques. And with robotics, you can do the same thing as the good old-fashioned Millins or the transvesical prostatectomy with laparoscopic and robotic techniques. So now the time has come. So I will end my discussion here. So these are the various treatments I said are the minimally invasive surgical therapies for BPH as first-line intervention therapy. Has its place arrived? This is a go-between surgery and drugs in certain patients who don't want drugs, who want to preserve sexual function. I have to tell you that in the developed world, in the West and in Australia, thank you, people do not go for upfront TURP or HOLEP surgery. They will prefer a minimally invasive because of rapid recovery, sexual function preservation, durability. So it is up to us surgeons to make these available in India. The best missed options are patients with medium-sized prostate shape, and there are many selection criteria. It's not for all. And the future directions will be individualized therapy based on disease progression and risk profiling, combining pharmacological therapy with minimally invasive options as a go-between, and shared decision between the practitioner and the patient, and re-evaluation of treatment goals. So thank you very much for giving me this time, and I hope I've been able to answer questions. I'll be here for some time more to answer any questions privately, if you can give me.
Thanks, Dr. Sarkar, for completing it before time. Thanks a lot of you. We learned a lot of things, what newer therapies are available for prostate. We learned a lot of things. Please stay with us.
Dr. Sarkar is requested to move to the selfie zone after opening the caller mic to receive the mementos, honorary mementos, to be distributed by the President of FPA, Dr. G.C. Gulgulia. You kindly receive your mementos come this side, sir, to the selfie zone. Please come this side.
Thank you.
Please come this side. Dr. Gulgulia to hand over the memento to Dr. Kalyan Kumar Sarkar. I've got a small announcement for the attendants of this conference, delegates of this conference. Those who want to achieve credit points must put in 2 signatures. One, an entrance signature, and the other, an exit signature at the end of the conference in order to secure the credit points. One signature won't do. You have to put in 2 signatures, one at the entrance and the other at the exit, so that you get the credit points. Okay? Now over to Dr. Chandan Pal for the next speaker. Dr. Rajiv Dhal, co-chairperson, has arrived a bit late. May I request the audience to give him a round of applause?
Yeah. Good morning, everybody. Our next speaker is Dr. Sunil Baran Das Chakraborty, and he will be speaking on endoscopic ultrasound guided interventions, techniques and outcomes. We are all waiting to hear from you, Dr. Chakraborty.
Just to mention, the first topic was supported by Woodlands Hospital, and this topic is supported by the Disan hospitals. So thanks to both of them.
Dr. Das Chakraborty is the HOD of the Gastro Department of Disan Hospital.
Good morning, respected chairperson and my dear colleagues. I must thanks to organizing committee for giving me this opportunity, and it's my pleasure to be here. And today we all are here to discuss about US intervention. So the US is evolved from a purely diagnostic tool to a sophisticated intervention tool, and it has a significant impact on the patient management nowadays. So it is a echoendoscope is a minimally invasive technique that combining endoscope and high frequency ultrasound precisely to diagnose and treat the gastrointestinal disorder. It allows the tissue sampling as well as the therapeutic procedure. So there is 2 types of echoendoscope available in the market. One is radial echoendoscope and another is linear echoendoscope. Radial echoendoscope has a 360-degree viewing angle. Has a 360-degree viewing angle, so it's like an axial CT scan. It gives a better positional relationship of the lesion with the surrounding structure. But it is only have a diagnostic purpose. It doesn't have any therapeutic capacity. Whereas linear echoendoscope has a viewing angle of 100 degree to 180 degree. And here the sonic wave is parallel to the shaft of the scope. So it gives a better relationship with the lesion with the vascular structure. And it has a biopsy channel and it has a therapeutic capacity. So we can do biopsy or any therapeutic procedure only with the linear echoendoscope. So what are the procedure? There is a long list of procedure by echoendoscope we can do. We are just discussing the few of them. The most important and the most commonly is a tissue sampling by FNA or FNB needle from the abnormal area adjacent to the GI system. And another is a drainage procedure like in pancreatic pseudocyst or pancreatic fluid collection in acute pancreatitis or chronic pancreatitis. We can do through transgastric or transdural approach. Biliary intervention like a drainage of the obstructed biliary system by transgastric or transduodenal approach. We also can do a vascular access like an US guided coil embolization of the gastric varix or even coil embolization of the splenic pseudoaneurysm by transduodenal approach, or injection of the therapeutic agent directly into the tumor or celiac fluxes to relieve the pain in a patient of chronic pancreatitis or CA pancreas. So now I am discussing on the US guided FN or FNB. So it is a highly accurate and minimally invasive procedure. Basically by echoendoscope we use an ultrasound to guide a needle to sample from the abnormal tissue from near the GI tract, and it is a very high success rate and avoid invasive surgery for diagnosis and can sample from the various locations. various locations from like pancreas, liver, gallbladder mass, mediastinal lymph node, abdominal lymph node, and more other area also. And it also somehow help in staging of the cancer. So common area we can approach, these are the common area we can approach to the echoendoscope for tissue sampling. What are the risks? The most of the procedure, echoendoscope, US FNA or FNB sampling is a basically very safe procedure. The risk is or complication is very minimal. The mild abdominal pain can occur after the procedure, but it is very less. Bleeding, dissemination during tissue sampling from the tumor, though it is practically possible, but it does not affect the survival rate. Pancreatitis can occur when we sampling the tissue from the pancreatic mass or for the autoimmune pancreatitis taking the pancreatic biopsy. Infectious disease can transmitted, pyriform fossa injury and the duodenal perforation. These two can occur with an echoendoscope. Because echoendoscope, the tip of is 6 mm to 1 cm tip is beyond our visualization of the by endoscope. So we have to manipulate the area, the bend with this echoendoscope very carefully. So there is chances of pyriform fossa injury or perforation and duodenal perforation is very common in a unskilled person. Contraindication, there is few contraindication. There is bleeding diathesis is a contraindication for any therapeutic procedure, but diagnostic echoendoscope is not a contraindication. If it is suspected there is periprocedural morbidity or mortality is very high in a patient, then there is a relative contraindication. Or the patient has a respiratory distress, a very high significant respiratory fluctuation, then it is very difficult to do therapeutic procedure like either FNE or FNB or any drainage procedure. But FNA and FNB we can do it even with a respiratory fluctuation. We have some modification, there is some pressure over the abdomen with a pull technique that we can avoid the injury to the other organ during respiratory variation. But for the therapeutic procedure, we need to come the patient, because in therapeutics when there is so much respiratory variation, so it may hit the surrounding structure. Most important is the blood vessels. And US FNA has a sensitivity of 80 to 90% for detecting the pancreatic disease, 25 to 100% for the biliary disease, because there is wide range, because the biliary tract tumor is very small. So less than 1 centimeter, it is also very difficult to target from the echoendoscope also. And for diagnostic, the subepithelial lesion echoendoscope with FNA or FNB is a very high diagnostic accuracy. So what are the, which is a better, FNA or FNB? FNB is always generally superior to the FNA, particularly targeting the solid lesion. It has a higher accuracy, better sample adequacy, fewer needle pass, and often eliminates the rapid onset evaluation. This is ROSE. Basically, when doing FNA, we just spread over the material over the slides and we just examine the macroscopically whether there is material or not. So this is called a ROSE technique. But during FNB, it doesn't require any ROSE technique, because during FNB, we collect the core tissue structure. Next, what the comparison diagnostics are already told, that is always better with the FNB. The needle passage requires less in FNB because material come with FNB is more than FNA. Tissue sampling is also better with FNB. There is no requirement of the ROSE technique in the FNB procedure, and but both are safe and similar complication rate. These are the needle. I am not going into the details of this. There is some difference in the FNA and FNB needle. FNB needle doesn't have any side core, but FNB has a side core that basically the core tissue receiver. It helps in the collection of the tissue more efficiently. So I am not now presenting some real-time video during our procedure. This patient presented with the epigastric pain, anorexia, weight loss, and the routine investigation revealed only elevated alkaline phosphatase. And the ultrasound abdomen shows such a liberation in the left lobe, and triphasic is the enhancing march in the left lobe. So left lobe is very difficult to target it from the ultrasound or CT guided, because they are very close to the cardiac structure. So here we plan for a echoendoscope guided biopsy. Excuse me, video start working.
I think there is a technical glitch with the slides, but I'm sure we'll get over it. Can we proceed? While we are waiting for Dr. Chakraborty to set his slides again, I think the audience can think about questions which they might like to ask him during the lunch session, because we are not allowing any questions during the scientific session, but you will have the opportunity to ask them.
On the floor of the conference.
Yeah.
But not on the stage.
And all the faculty will get their mementos from the selfie zone at the end of the lecture.
Okay. As far as CAV credit points are concerned, please ensure that you have got 2 signatures, one for the entrance and the other for the exit, in order to secure the CAV credit points at the end of the conference. And the certificate will be probably given away at the end of the conference today. Please bear with us, we are held up because of a technical glitch. We hope to overcome it within a few minutes.
Sorry for the interruption, then I can begin. Now it is working. So these patients presented with the epigastric pain, anorexia weight loss, the only abnormality have an elevated ALP and found to have an SOL in the liver, MNC mass. So we did an endoscopic ultrasound biopsy. There is a liver at the left lobe. We are taking, these are the FNP needle. We will push from the transgastric approach, and we basically accentuated the needle into the mass under direct vision, so there is no injury to the surrounding vessels or hepatic vein. We usually pass 4 to 5 passes in a fanning technique. Then we collect the sample in a formalin and just observe there is a core tissue or not. Then again can we do and repeat the procedure. Again. Similarly, another patient. This is a 2 different video showing the 2 different pancreatic mass. This is the first one. Is a very small mass. An 8 years old male present with obstructive jaundice found a very small mass, 1 centimeter mass in the head of the pancreas. So this is very difficult to target from the US or CT guided biopsy. So we plan for US echo endoscope guided biopsy, and this is the mass, this small one. This is the portal vein, and this is the superior mesenteric artery. So the mass around the distal, most distal part of the CBD. This is an hypoechoic heterogeneous mass. So we targeted the biopsy from the transduodenal approach. This is the needle. So it's very carefully passed into the mass, and we taken 3 or 4 accentuation not to injure the vessels and not to the CBD also. So we taken the sample from this and subsequently is found to have a neuroendocrine tumor. Next, in another patient, this is a solid lesion, solid pancreatic mass. This around 2.5 to 3.5 centimeter mass, and this is a solid mass, and this is a large mass. So it is very easy to target from the duodenal approach by an echo endoscope. We also have taken the sample from this lesion by an FNB needle and is found to have an adenocarcinoma. Next, the mediastinal lymph node. This patient presented with an 64 years old male with a non-specific cough for the last only 3 weeks, and the patient has some difficulty swallowing and also had some back pain and chest pain. On CT found that a large subcarinal mass with emphysematous changes involving the both lung, and the patient has a some respiratory distress also. So initially we did an endoscopy, but the initial endoscopy was absolutely normal. But when we planned for echo endoscope guided biopsy after only 7 to 8 days, then we found that mass involved the esophagus completely, and there is complete ulceration between the mass and esophagus. So we did a biopsy very carefully because there is a chances of tracheoesophageal fistula at this time. So this biopsy by endoscopic biopsy is very difficult to ascertain. From this we are suspecting a tracheoesophageal fistula in this group of patients. So particularly in this group of patients, we usually avoid an endoscopic biopsy that may accentuate the fistula. So we plan for an echo endoscope guided biopsy from the subcarinal mass. So this is we basically this approaches from the esophagus at approximately 30 centimeter from the incisor teeth, and we are seeing in the left right atrium, right pulmonary artery, and the below is in ventricle. So from this approach we have to be very careful not to puncture any blood vessel, because these are major blood vessels. So if there is any injury during blood vessel, that may lead to the serious complication in perioperative period. So we taken a sample from this mass, and this found to have an adenocarcinoma. Next is showing a video of another patient. This 17-year-old female presented with obstructive jaundice, and the patient has an anemia with recurrent malaria requiring multiple blood transfusion, and she has a history of more than 20 blood transfusion in the last 2 months. And the upper GI endoscope shows large infiltration lesion involving D1 D2 junction with oozing from the surface with luminal laving. The initial endoscopy biopsy is negative for malignancy. CCT abdomen shows the large GB mass involving duodenum that causes compression of the distal CVD. There is no direct involvement of the CVD here. So we plan for a echo endoscope guided biopsy from the GB mass. So here we approach from the transgastric route. Around the lesser curvature, we first identify the mass, then we target with the FN needle. We done in a fanning method, and that biopsy turned out to be adenocarcinoma. Next, nowadays is now evolving the liver biopsy. The liver biopsy can be done through the ultrasound guided liver biopsy, or nowadays in echo endoscope guided liver biopsy. Both are equally safe. Complication rate are similar in both cases. But US guided liver biopsy has a diagnostic accuracy. Both have an equal diagnostic accuracy for liver disease, but US guided liver biopsy is preferred because of superior efficacy, shorter recovery rate, and ability to sample from the both lobe of the liver, and is as a less pain because we will approach from the stomach. But on the other hand, ultrasound guided liver biopsy is less costly. It provides a longer specimen, particularly in a liver. There is a more portal structure is available in ultrasound guided liver biopsy. But nowadays US guided liver biopsy is as efficient as ultrasound guided liver biopsy. So this is a presentation of a female patient. They presented with the abnormal liver enzyme over the last 2 years. Then he is referred to us, found to have an ANA positive, and autoimmune hepatitis scoring is around 9 to 10. So we need a liver biopsy to confirm the autoimmune hepatitis. So we did an US guided liver biopsy. Usually US liver biopsy is done from the left lobe, the segment 2, or other is segment 3. But we can take from the right lobe of the liver, from the antrum or other area. So we did a liver biopsy and we sent the sample to the histopathology, and this found to have an interface hepatitis. That is the lymphocyte infiltration in the limiting phase. So it now is diagnosed case of the autoimmune hepatitis. Now she is doing well with an immunocompromised azoran and omnipodil therapy. So nowadays it is evolving. The US guided liver biopsy is very common nowadays. It is replacing almost the ultrasound guided liver biopsy. Next therapeutic procedure we routinely doing is the celiac plexus block or celiac plexus neurolysis. Celiac plexus block with an bupivacaine or triamcinolone combination injected this material into the celiac plexus under the direct endoscope and echoendoscope guided. And in neurolysis we injected absolute alcohol. The benefit of the US guidance is that it is a real-time visualization with improved accuracy and safety and better identification of the critical structure, that is the celiac artery and aorta nearby. So this is then pictorial with a diagram. This celiac axis plexus, basically we approach from the transgastric route. First we identify the aorta, then we identify the origin of the celiac artery, and the angle between these two is in celiac plexus. So injected, we pass the needle through the transgastric routes very carefully into the celiac plexus region. Then we inject either bupivacaine translation or absolute alcohol. So I am showing the real time which is a video we have done in our department. This is an abdominal aorta and this is celiac artery. So this area is basically a larger image. This is celiac artery origin and this area is a celiac plexus area. So we passed a needle to the transgastric approach and then we injected bupivacaine and triamcinolone under the echo-Doppler guidance. So this procedure is a very critical procedure, not to injure any celiac artery or aorta because these are the major vessels. If any injury to this structure, that may lead to life-threatening complication.
Another 2 minutes left.
So outcome and safety both are equally efficacious. Next, in US guided biliary drainage, particularly is very helpful when the ERCP fails. So there is 3 types of procedure. One is a transpapillary invasive procedure and other is a direct transluminal approach by colorectal and hepatogastroscopy. So the endoscopic are not going into the details. It is a more complicating and more cumbersome procedure. This is a direct transluminal approach, either by colorectal or by the hepatogastroscopy. Colorectal, we did the procedure from the approach from the duodenum. We directly puncture the leaf. I'm coming into the video directly. We passed the echoendoscope into the duodenum and we identified the CBD. This is CBD. This is CBD. Then we punctured the by 19 gauge FN needle directly into the CBD. Then we then we aspirate the bile to confirm whether in the biliary system or not. Then we inject contrast and see another fluoroscopy, and that gives a visualization of the whole CBD and biliary system. Then we pass the guide into the CBD. Then the tracts was dilated with the 6-string cystostome. It's a guide. This is an endoscopic view.
Hello. Yeah. The time is almost over.
It will take another 2 or 3 minutes.
Yeah, it is. Yeah, we know you lost
the tract was dilated with the cystostome. Under the endoscopic views and as well as the ultrasound view, both. Then we place an colorectal with self-expanding metal stent across this opening, and there is a good flow of bile can seen. And the post procedure the patient is absolutely doing well, and the bilirubin comes from the 20 to almost normal level after 3 weeks. This is self-expanding metal stent. This passed through this opening or fistula we had made, and then we place the metal stent in the duodenum across this fistula into the CBD. Next, another is a hepaticogastrostomy with the approach in basically through the segment 2 or segment 3 biliary tract, which is biliary tract of the liver. The dilated bile duct of the segment 2 or segment 3 of the liver will directly puncture into the liver, and the procedure is the same, but we approach this system from the stomach. I'm not going into the video. Then there is an US guided pseudocysteines. Now it is very common doing routinely in our department. And efficacy is almost same. It is nowadays echoendoscope guided pseudocysteines or pancreatic fluid also become the standard care of treatment. It is better than surgical management or percutaneous ultrasound guided approach. But the requirement is this: the collection should be between the distance between the gastric wall or duodenal wall and the collection should be less than 1 centimeter. Also doing routinely as an US guided tumor infiltration, particularly helpful pancreatic NET or pancreatic adenocarcinoma smaller one. So now the take home message: the US has evolved from a diagnostic to an interventional platform. It is an important modality nowadays for management of the pancreatic biliary disease. Future hold many exciting prospects for the interventional US, and control trial is critical to show which intervention will become available. Thank you.
Yeah, thank you, Dr. Chakraborty, for showing those excellent practical procedures. Now, next speaker.
No, just wait. Please excuse.
Yeah.
Dr. Das Chakraborty is requested to move to the selfie zone to receive his memento from Dr. Pramod Jasani, Founder Secretary of the Family Physician Association, Kolkata. Delegates attending this conference, please put your hands together loudly. Otherwise, speakers won't come to our conference next time. Okay? Drive away the winter chill by putting your hands together and spreading warmth. Okay? Dr. Sunil Baron Das Chakraborty receiving the memento from Dr. Pramod Jasani. Now, one important announcement: breakfast has been declared to be closed. Those who have missed their breakfast can have it, try and have it, but breakfast has been declared to be closed. Over to Dr. Chandan Pal to call the next speaker.
Now, let me have the honor to call Dr. Anjan Shiotia upon the stage. We are happy that off and on we get a chance to hear him on the latest advances of cardiology. Not only he attends our relevant lectures in our annual conference, but in the mid-time lectures we also get him on the APA dais. Now welcome Dr. Anjan Shiotia.
Dr. Thal is leaving the auditorium for a few minutes. In his place, Dr. Shakil Akhtar, Vice President of the FPA, will continue as the chairperson.